Okay, thank you everybody for joining the Injury Prevention plus Seek QI program action period call number 3. We have made it to the third action period call. It's March already. Time is flying by. As always, we want to thank our program partner, the Ohio Department of Health, the Violence and Injury Prevention section. In today's agenda, I want to welcome all of you. We'll hear from Zainab with the data review, and then we have Triple P America on with Courtney Town. Very happy to have her. And if there's time, QI Corner and next steps from me. Okay, so if you can do so safely, please so in the chat, share your name, your practice, and what you are seeing in your practice right now. Are you seeing more patients for sick visits or for well visits? Okay, Zainab, I have your slides.
Thank you, Brooke. Thank you everyone that submitted their data. I know we only had one of our coaching calls with one of the practices so far, but I just wanted to take the time to thank everybody for submitting their data. Today you'll see some additional slides than what we've usually been seeing. So we'll see just the usual that we always see, but then some additional. So if anyone does have questions, please let us know. I'm going to go through the first few slides fairly quickly because we've seen them usually. But as we get to the end with the newer slides, I'll take a little bit more time there. Ready for your first slide, Brooke? So everyone was doing great in terms of screening. Here, screening means that once the patient starts the survey, they complete all of the questions on there. So the majority, almost everybody had 100% screening for all of the topic areas. Counseling, we did see a little bit of a dip in the 13-month to 5-year age group. So the older age group, we saw a dip from 97% to 89%. And then for the birth, we saw a little bit of an increase from 71 to 74. Next slide, please. Family needs, again, here at 100% in terms of screening. We did see a little bit of an increase from 85% to 89% from January to February for the older age group, and then a little bit of a dip in terms of family needs for the younger age group. Home safety, and this is our largest topic area, includes questions like securing furniture safely, which we had a great presentation about last time, and other like home safety questions. Screening was at 100% perfect. Counseling hovers at mid 70s, which we saw very similar numbers in January. We're hoping to get those numbers to increase a little bit, but overall, like I said, this is our largest topic area with the most needs. So understandably, there might be some missed counseling here. Just one more reminder, if you're giving them your or our resource sheet, our AAP resource sheet, please give yourself credit for counseling, even though there was no time for a verbal counseling session. We do have resources on there that are useful and can be considered as counseling for the patient if they receive that tool. Next slide, please. Car seat safety, again, for screening at 100%. We saw a significant increase in the birth to 12 months from 40 to 83%. And then also an increase in the older age group from 58 to 71%. Next slide, please. Safe sleep, again, at 100% in terms of screening, and then counseling hovering at about high 70s from actually last month of baseline to February. These are the slides that we see every month or every time we have an action period call, as well as some other slides that you'll see. But then, like I said, we have included some others. So these are for the actual survey, and then now we're going to jump into the caregiver feedback survey. Next slide, please. Or I'm sorry, I was one slide ahead. This is the resource sheet. This is the resources, any resources that we've provided or any resources that you've provided them or even the resource sheet that we have given you. We did see a little bit of a dip. We saw a dip with some practices. Please let us know if you're either missing resource sheets, you don't have any more, they're done. That number has decreased a little bit from baseline. So if you're still consistently doing what you used to do in those baseline months, please, let us know and put that, put that in your survey. So Brooke said something last time that I really thought was accurate, is that there's things going on at your practice that are not being accurately reflected in the data that you're submitting. So we know that there's good things going on, but not all the data might reflect that. So please, take the time to put that data in as accurately as you can. Um, Practices won't be docked any points for decreased rates, but we still want the practices to perform excellently, and we want, for you to provide excellent um, care to your patients. So please let us know if there's anything that we can do to help with that. Next slide, please. This is one of the newer slides. So I know that we always ask every month for your monthly patient totals, and so this is where that comes into place. So of those patients that come in monthly, 40% of those in January received this screening tool and 33% received the screening tool in February. That's relatively low where we usually aim in projects similar to this to about 80%. 80% of your patients that come in receive the screening tool. So this is just some information for you to know. Um, if there's any possible way that we can get more of those patients to receive the iPad and to complete that screening tool or the paper screening tool, then that would be great. We're hoping to see that number increase just a little bit more, um, and hopefully we can get to that towards the end of QI. Next slide, please. This is the caregiver feedback survey. Um, the second part of the survey that the caregiver fills out. This includes, questions like whether or not they're willing to change, if they learned anything from their visit today or that specific day, and that's at 92 to 90%. So great. So 92% of the patients that are completing the survey are also completing the family feedback survey. Next slide, please. In the caregiver feedback survey that I just mentioned, there are questions like if they plan to make a change. So if there's a need for a specific topic or a specific question, then they're asked whether or not they have an intention or whether or not they make a plan. They plan to make a change. So 89% of the needs caregiver for 85% of the 89% of the needs caregivers are planning to make a change. It's a little bit of an increase from last month, and that's great. Again, this is more caregiver orient. This is more of their personal responses. This is not something that you can control. This is just us letting you know what it looks like, what for all of the practices combined. Next slide, please. And then on a scale of how likely they are to make a change, ready to make a change, seriously considering making a change, thinking about changing, should change but not quite ready, and no thought of changing, we have this scale. The majority are ready to make a change, and then the second majority are seriously considering changing. So those first two groups make up almost 70% of of all of the needs. So all of 70% of the needs have some plan to make a change. And then thinking about changing, and then the rest also have increased since last month. This is something that you've not seen before, and this is one of the portions for our underrepresented group. I know in our call yesterday, Brooke had mentioned that there are portions in the survey that we would love for you to complete. That information is reflected in these few slides that you're going to see shortly. So our underrepresented group includes three things: race. So the two race groups that we're looking at are African Americans and other races, and that includes some Native Americans, Asians, other mixed races that do not include African American. And then we have Hispanic ethnicity and Medicaid holders. So these bars are not mutually exclusive. So someone can be African American and Medicaid holder. Someone can be Hispanic, African American, and a Medicaid holder. So technically that patient could be in any of these columns multiple times, right? So they can be in each of them or in just one of them. So these columns is a percent of uh, completed screening tools submitted by each group. So of all of the screening tools, we have 65% in January that were Medicaid holders, about 70% in February that were Medicaid holders. And so that's how to interpret this data. The majority, again, are Medicaid holders. We see higher percentages of African American race compared to other races, but um, again, this is just some data, background data on how to interpret these charts. Next slide, please. This is the counseling. These are the counseling rates. So of the families that are saying that they have a need, how many of them are being counseled? So of those needs, how many of those needs are being counseled? So that's actually what the counseling rate is. Um, and the first larger chart that you see, that's all of the needs, regardless of what kind of topic it is. And then on the side, we have the injury questions or the injury topics like the family needs and the social needs, and then the social determinants of health, which are the home safety, car seat safety, or no, that's the opposite of,
Switch
yeah,
that. Yeah.
yeah. Sorry. Injury is home safety, car seat safety, safe sleep, and social determinants of health is family needs and social needs.
The
Sorry.
first page of questions, the first 13 questions.
Yes, yes, the first 13 questions. So you can see here that if you're looking at it overall, in January, the Hispanic race did not seem to have a lot of their needs counseled. We're at about 65% there. That was the lowest percent that we saw in January. The rest of the groups are at about 80 to 90%, which is great. In February, those numbers did increase. So we're still seeing for Medicaid patients, which again, that's the largest portion of the patient population, we're seeing 80% of their needs being counseled, 100% of Hispanics, and then African Americans a little bit lower than that. For the injury questions, for the injury topics, again, we're seeing high numbers for um, the majority of the underrepresented groups in terms of counseling on needs. Um, we do see lower counseling rates for African Americans um, for injury questions in January, and we also saw lower numbers in February as well, but still pretty good. But again, this is just a reflection of what's going on, so that you can understand that there are definitely some opportunity areas and where you could focus a little bit more of your effort if time allows, if you have the capacity to do so. And then the social determinants of health, those are a little bit lower in terms of counseling. And again, this this includes social needs and family needs. So those are more questions that are family related. So, again, this is a reflection of what's going on. We are seeing lower numbers overall in terms of which questions or which needs are being counseled on. Um, low numbers in Hispanic, low counseling rates in Hispanics in February. Um, and then also in January, we saw 80% for African Americans, Hispanics, and Medicaid holders. So please, make sure, like I said, that you're giving the resource sheet to everybody that you can, um, especially the resource sheet that we're providing. I understand that a lot of practices already had some resources at their practice that they were providing. If you've been doing so, please continue to do so. And then if you can, just add our resource sheet in there so that you can give yourself credit for counseling. Um, I think this is the end of my slides, Brooke. If anyone has any questions, please let us know. I can see that there's some things in the chat. I don't know if any of these are questions, though. I
I
don't
have not
think
seen
so.
any questions come through, but please feel free to reach out if you do have any questions. And then your practice coaching call for March is a good opportunity to dive in further too. And speaking of individual data, that will be coming to you next week.
Perfect.
Zainab, thank you.
Thanks, Brooke.
Courtney, happy to have you. I have your slides loaded if you would like me to drive, but very happy to have Courtney Town, an implementation consultant from Triple P America on today. And Courtney, just a fun fact, we sent out the Triple P resources to our providers, and I can confirm that some of them are using them in their practices.
That's so great to hear. Thanks, Brooke. I'm really happy to be here. Good afternoon. All right. So yeah, the main thing I want to do is just, raise awareness, hopefully, if some of you may not be familiar with what's available in Ohio around Triple P resources. And so I'm just going to share some of the work that we've been doing in partnership with the Children's Trust and the funding that they receive and from the Department of Children and Youth, as well as from the Governor's Children's Initiative, just really have a vision for trying to scale evidence-based practices that support parents in ways that are hopefully accessible and flexible. So we're going to dive into that a little bit. And my role, I work for the Triple P program, and I've been partnering with the Children's Trust in, supporting their implementation of the model for well over about 10 years now. And they've been at it longer than I've been working with them at it. So it's really, really great to see where we are now and some of that history. But yeah, there's a lot of content on these. I don't plan to go over all of it in detail, but hopefully, I'm sure, Brooke, you can make these slides available for everyone to have as a reference if there's anything you want to kind of go back and dig into more. But I'm going to go through stuff fairly quickly. So don't worry with all the content. I don't plan on reading slides to you. Thanks, Brooke. Next slide. Okay, so hopefully just making the case, and I hope that I don't have to convince anybody why, but there's lots and lots of reasons where we are just really passionate in believing that parents really can benefit from having more support around the job of being a parent. So lots of reasons out there that affect lots of different systems and sectors and outcomes, and just thinking about what we want in terms of children's well-being. But here are some statistics in the last couple of years, just making the case a little bit more around there's challenges. Parents are really struggling with a lot of different things. We have rising incidents of school avoidance happening for children, lots of competing demands for families, attendance is really wavering. There's a stat here about even just third graders missing more days of fourth graders missing, a lot of school. I'm certainly hearing that across the different age ranges. We know that we've got much higher numbers involved with the juvenile system in Ohio. Some really great things happening, though, in terms of linking those parents to Triple P interventions, which is encouraging. Continue to get the screenings that are really high from the child welfare partners that we have around the state. And we're doing some good pilot work there with PCAs in several counties to really try to, again, get more flexible resources for parents that can be actionable and supportive more quickly and really tailored to what they're working on. And then you all know, I don't have to say anything about ACEs to this group and how important it is for not only like mitigating ACEs, but also hopefully preventing ACEs if we're really getting in early enough with parents, equipping them with confidence and the tools that they need to, feel like they can manage daily tasks and lower their stress. And then we've got a workforce shortage, right? So that's all of this kind of making the case for why we think we need some more flexible options, not just in terms of what parenting support can look like, which Triple P has been designed to do, in its flexibility of delivery formats and options for parents, but also just thinking about that, the workforce shortage and how do we bring maybe non-traditional providers and partners into being able to support parents with evidence-based strategies. All right, next slide. So we really look at this as kind of a shared approach. The Triple P model has been designed to work in partnership in communities. So it's something that really crosses into different sectors, and we bring a lot of different people to our Triple P table, hopefully. And we're really targeting all parents with something. So this idea of having a flexible system where we're going to try to be there in the right place, right time, right amount for parents, so that they have a lot of choice in that. And really thinking about what we can do to strengthen that parent-child relationship. Next slide. We go ahead and go to the next slide, Brooke, because I think it'll become more clear with that. So when we think about the Triple P model, it's really been designed to be a population approach, right? A public health model where we have different levels of intensity that can reach parents when they have different needs. But we have some common things that we see when we scale the program in communities. And these are really reliable in the literature on Triple P. And it's really great to see that we're seeing this happening, in places where we have larger scale rollouts, being able to promote kids' healthy development, really being able to prevent, like I was saying, we mitigate those ACEs hopefully, or even prevent them, being able to prevent children's social and emotional, challenges from developing any behavioral problems. We have a lot of literature that shows how triple P can prevent child maltreatment when it's scaled significantly. There was a great CDC funded trial in South Carolina that demonstrated really encouraging effects in counties, comparing just treatment as usual versus counties where we widely made the program available, and at a population level being able to see rates of maltreatment really significantly different in the counties where it was just services as usual, by just making this more available, having it widely disseminated, lots of different types of providers. To be able to see those outcomes was really encouraging, and was kind of seminal in thinking about like being able to prove prevention does work, right? We talk about it, intuitively know it, but it's nice to have some literature behind it. And then one of the things about all this is also like we're working really hard to destigmatize this whole idea of like parenting support, like trying to de-link it from classes or education or telling parents the right way to parent or suggesting that there's a wrong way to parent, but really reducing stigma around how that's typically been perceived and trying to normalize help-seeking behavior with parents, and I think, it feels culturally like we've made a big shift in that. I think parents are so much more on social media, talking to each other, acknowledging parenting woes, parenting questions. Also, though, with that, there's a lot of unreliable information that's not necessarily like backed up by literature about what's going to be effective. So how do we counter that, right? So really thinking about what kind of presence do we have? How do we cut through a lot of that noise and get to parents and help them, just be exposed to things that we know really can be effective and achieve the outcomes that we know that this model can achieve. But still need to do some work around stigma, because there's still a lot of folks that will associate parenting support with, problematic concerns. And there are, but that's not the only thing. We're really trying to make sure that we're getting parents in a way that feels like, yeah, why wouldn't I want to get more information about how to handle bedtime routines or how to handle like my picky eater or all the things that are just so normal that maybe don't make us think I need parenting help, but actually being able to be introduced to some strategies that could help make the morning routines easier, get us out the door on time would be super helpful. Next slide. All right, so just a little bit about the secret sauce, if you will, of triple P. The model has these 5 principles of positive parenting. So anytime parents are interacting with the program, whether it's one of our briefer or more intensive interventions, it's all really like steeped in these principles about helping parents think about the things that will create an interesting environment for their kids, a positive learning environment, helping parents be able to think about having realistic expectations as it ties into how they're following through with consequences and discipline, and having expectations of their children's behavior that are fair and reasonable. And of course, taking care of ourselves as parents, like what do we need to keep our cup filled, and not having expectations on ourselves that are unrealistic or impossible to achieve. We're really focusing on this idea. We're like, no, we're not looking for the perfect parent. None of us are ever going to be able to do that, right? So what can we do to focus on being the good enough parent day to day, having things mostly feel like they're going well? And we've got different strategies that are based on ages and stages for kids. So the triple P system has been developed again to be able to have everything from content for parents who are expecting or with infants, all the way up to parents who have tweens and teens. Next slide. The biggest piece of triple P that I think is a little bit of a standout in what we're going for, and why I think we see such good results with the model in so many diverse settings. So when I say diverse, I'm not just talking about Ohio, where we have really good like statewide examples in very rural parts of the state, where we have really good results in more of the larger cities, a lot of activity in Columbus and in Cincinnati and Dayton, but also like I see it globally. And I think it's because what we're really doing with parents is we're promoting their own self-regulation. We're really helping parents, like, if you're trained to be a provider in triple P, you are really meeting them literally where they're at. And we're going to find out what's important to them. What are their goals for change? What have they identified that they want to work on? And helping them think through more intentionally, what's that going to look like? We introduce them to some ideas and some strategies, always with the idea that you pick the one that feels most relevant to you. So never in the program are we going to be saying, do this thing. That can be kind of hard, honestly, for some of us who are trained to like be a little more prescriptive and tell parents, yeah, I know exactly what's going to work in this situation. But we're really with the triple P model, the point is to really help parents kind of come to that answer for themselves. They're going to be much more likely to try something new or implement a new strategy if they've felt that connection, that light bulb moment themselves. Like, I know myself, I know my child. You just gave me 3 strategies. That's the one I think I'm going to get the most bang for the buck on. That's the one I think I'm willing to try tonight. That's the one I can see actually working for me tomorrow. So really, again, through this idea of promoting self-regulation to build parents' sense of personal agency, their ability to problem solve, having that sense that they're sufficient in being able to handle things, hopefully we're having them rely less on feeling like they need an expert that's going to be there, that they feel more confident navigating those daily parenting challenges. And that's all about like tied into this idea of minimal sufficiency as well. In the Triple P model, we've developed it to be a system of different levels of intervention, but also within that, trusting parents to kind of self-select how much dosing they need, right? So what's going to work for them. And in our minds, if a parent felt like they got what they needed from a couple of contacts and they've made enough change in their family that they're feeling better about things, fantastic. And then you know what, they can always come back. So it's never a sense of like, this is the intervention and once it's done, it's done. We want Triple P to be widely available at lots of different touch points along that entire parenting journey. So parents can take what they need and, you know, at the times that they need it, and then come back to it as often as they need as well. Next slide. Okay, so this is just a visual of what I'm talking about with the system. We have, I keep, saying we have these different levels of intervention based on kind of flexibility and what parents might need. At the base of this, if you think about a full population, again, it's just that idea of we need to market to parents. They need to know what's available. They need to know where to get it, how to get it. We want to do that in a way that destigmatizes it and normalizes help seeking. So that's that kind of communication strategy that we talk about with Triple P. We've done a lot of different things in Ohio to try to raise awareness. Including, like Google AdWords and a Meta campaign, through Instagram and Facebook and advertising like that. And so we're like doing a bit of a revisit on that strategy right now and rethinking it a little bit, but that's been part of like being able to, we've reached 30,000 parents with the online course in Ohio to date, which is really cool. And yet we know there's still so many people that haven't heard of it. So we still have our work cut out for it. But this pyramid is showing you like, you build on this communication strategy. And then we're making available in Ohio, all these different levels are available depending on what community you're in. And at the end, I'll show you the website and the link to the website that you can refer parents to or go check out yourself. But parents are able to go there and see what's available depending on where they live in the state. So we have a lot of trained practitioners around the state that are trained to do these different levels of intervention. And then we've got the online course that's also available at no cost for any parent in the state that they can take. And there's, depending on the age of their kids, there's one for parents with younger children and there's one for parents of older children. So when you look at this pyramid here and you look at those levels, again, keeping in mind different levels of intensity, different formats for delivery, and based on ages and stages, we've got content that really covers the full age range. Next slide. Okay, so again, across what's really consistent with all those different levels of how we've, designed the program, promoting that self-regulation, parents determine the goal, practitioners, when they're trained to deliver it, they're really encouraged to come up with examples that are relevant to that family. And I think this goes back to, again, why we see in the literature base behind Triple P, we get such good results in so many diverse areas, like globally, because again, we're really having parents decide what it is that they want to work on. And we're really like tuned into like, how is this going to be relevant for them? We give them ideas, we help them make informed choices, but they're really driving it. So parent-led, parent-driven. Next slide. Okay, I've touched on this a little bit, but the idea again in Triple P and what's a little bit unique about it from some other models is we want to have as wide of a net in the community as we can. We like to bring lots of different folks to the table in terms of who can be, providers and get trained to deliver it with their families, but also just, what are our roles in as community members and being like hosts, so maybe inviting other community partners into our site to do these things. Bringing in other people that are trained to be providers to deliver it to our population, certainly making referrals to parents and being more informed about what's available. But we have trained lots of different provider types around the state in lots of different sectors with lots of different opportunities. That's kind of the cool organic thing about it is I think it looks really different in every community, and it should. We don't have the same workforces. We don't have the same, funding resources. We don't have the same needs necessarily with different families in every community. So really being able to tailor it is a big part of the work that I get to do in partnership with our folks that are implementing. Next slide. Okay, I've said this many times, but for real, it's really well researched. It is, I think, fair to say it is the most researched evidence-based parenting program in the world. But we're not satisfied with that. That's the cool thing is there's ongoing research. There's new curriculum coming out all the time. There's new education curriculum. The best example is that we just released about a year and a half ago now, what we call Fearless Triple P. And we've trained several people around the state to deliver this model. It's a newer variant, and it's focused on parents of children with anxiety. So going back to that first slide and thinking about school avoidance and thinking about what an issue that is and the statistics on adolescents, anxiety and depression right now, and the levels that we're seeing with that, we've released this new curriculum that really equips parents to be able to confidently address the skills that their children might need to cope better, to manage their worry and their anxiety. Again, we know we don't have the workforce, right? We just don't. We've got kids on waiting lists for behavioral health screenings that are like months and months long. I just did a great partnership with a hospital system in Wisconsin, and we did this it was them, but Triple P was part of it, but they did the work. But they were able to do this intensive intake triaging day where they just really met with all the families on the wait list, everybody all hands on deck. We're all just going to do screenings all day. They moved over 400 parents off of their intake list over to Triple P Online. That was going to be the right intervention for them. They weren't in they didn't really need a behavioral health intervention or even an assessment. They really were struggling with some things that could be addressed through that curriculum and referred to that program and then followed up with coaching. So we're able to save that higher resource, more intensive need for parents with something that was going to meet their need more immediately, give them concrete things they could start to do differently that day. So just really, really nice to kind of think again about the flexibility of that. So lots of research ongoing, keeps it fresh, hopefully introducing new variants. But the cool thing is that the basics, a lot of that stuff that's been around now for over 40 years has not needed to change because it's so universal and it's so strength-based and it's so parent-driven. All right, next slide. Consistently, the research shows that we're going to improve positive parenting. We always are seeing parents reduce those strategies that are more kind of coercive. So the bargaining, the yelling, the negotiating, the pleading, the begging, the threatening, all those things, those decrease for parents in terms of their go-to strategies when they get introduced to different ideas of maybe how to respond differently. That would make sense that what we then see is fewer behavioral and emotional challenges for children. When that's happening, obviously, we're going to improve that parent-child relationship. And when that happens, we're going to see a decrease in parental stress, which is huge. There's our model's out of Australia, and there is a large countrywide project going. And it's been really cool to tie parenting support to productivity and workplaces. Totally makes sense, right? Most of us are parents in the workforce. We've got our own things we're thinking about. I'm not excluded. I've been texting with my ex about my stepdaughter today. And what are we going to do about school? So it interrupts our day. We're thinking about it. And so to be able to tie in being able to access parenting support in a way that's so ubiquitous and just so widely available can start to see changes in, productivity at population levels and workforces and large workforces. So it's been cool to see some of that. Next slide. All right, as I said, feel free to check it out, on just different clearinghouses if you're not familiar with these, but several different entities. Hopefully people keep their funding for things like this, we'll see. But there's lots of entities that are able to kind of look across the literature and compare different evidence-based programs and think about the literature behind them and, give you kind of good guides to think about when this, what's this program about, who's it for, that kind of stuff. And Triple P is, of course, cited on many different clearinghouses and kind of thinking about different areas. Next slide. Okay, and then a question we often get is with people wanting to make sure that Triple P is a trauma-informed model. And absolutely, there's so much baked into how Triple P was even developed that is trauma-informed if you kind of go back and think about that. But just again, all of these things are really inherent in how the model's been designed. So we've got some really good literature and some one-pagers that help connect this, and we make it clear in training just about the ways that the model is trauma-informed when it comes to thinking about best practices there. All right, now we're going to talk a little bit more about, next slide, what's going on in Ohio. As I mentioned, the Children's Trust Fund has been making this program widely available for over 10 years, which is really fantastic. And with ARPA dollars, that was when we were able to go big or go home. The state was able to use those one-time funds. It just was, it just made total sense. We can't really sustain programs that have a lot of staff. We can't sustain things that have a lot of infrastructure after these ARPA dollars go away. But investing in making the online course available free to all parents that made a lot of sense budgetarily to be able to make a big investment. So that's how we've been able to purchase enough codes in Ohio to make this free to any parent, and how we've been able to reach over 30,000 parents and counting is, like building on some of those COVID dollars. But now we've been able to show those results. We're reaching parents in counties that don't have a lot of other resources. And in those counties, we see parents engaging with the online course at a higher rate than those that live in counties when there's more resources available. And that just intuitively makes sense. We're also seeing some really nice things in terms of some demographics that are engaging more with online than what we typically see coming into services. So seeing more dads, completing the program online, seeing parents of color that might not, consistently attend some of the other parenting options that might be available, engage well with online and like it. So really good satisfaction rates, an increase in confidence for parents going through it. Really good stuff. This just is kind of, again, talking about the history there and the support that we have from DCY and the Governor's Children's Initiative, with this vision of really trying to scale parenting support in a way that makes it widely available. Next slide. This just shows some of where we've been in the last couple of years. So this takes us through June of 2024, the last fiscal year that we were looking at, state fiscal year, and just being able to see again, like we're really, it's hard to see, I know with the size of this, but those yellow triangles are where we have higher poverty rate counties, where we have higher child maltreatment. And really, we're paying attention to this. Like, we want to make sure, even though we're offering a universal program for every parent, we also are, wanting to make sure that we are reaching parents who may be more vulnerable, who, may be at higher risk for maltreatment, and making sure that, we're hitting parents like all over the state of all varying needs. So just really a lot of tracking goes into that. We've got outside evaluation happening through researchers at The Ohio State University, as well as University of Michigan. Next slide. Okay, so just a little bit more about Triple P Online. Again, my hope for you is that, you'll talk to parents about it, refer them to it, refer them to the website, like reach out if you have any questions about it. But the level of the online course, as I mentioned, is available for parents with younger kids or with tweens and teens in English and Spanish. And it's really built on the full curriculum of Triple P. On that, pyramid slide is kind of what we call level 4. That's where we introduce parents to all of the different strategies in the full curriculum. But it's really, next slide, it's really interactive. So as parents are going through it, they're going to be able to do it at their own pace. They're going to be able to engage with the exercises that stand out to them more or less, depending on their interest. So it's really self-directed, really able to go through it and get what you want out of it and what feels relevant. This just kind of shows some of the content, and you'll have this slide to go back to. And we've certainly got lots of other information. If you feel like you need more, just reach out. But they're going to get, just different video clips of seeing things in actions, exercises to do. Next slide, they get to save different resources on there so that they can really see, like what's available there. When a parent registers, they're going to have access to the course for a full year. We work closely with our partners at Nationwide Children's Hospital. They send out a welcome email to all parents, and they offer coaching. So if any parent is feeling like, this is great, but gosh, I'd really like to talk to someone too, we do have coaching available. And so that's free and that's provided. Next slide. And then this just shows a few clips again of like, some screenshots of what the online course looks like. I'm always happy to give anyone a free, you don't have to go to the website and use one of the Ohio codes. If anyone ever wants to check it out themselves, or if you want to see some of the courses that aren't available in Ohio, reach out. I'm happy to give you free access to any of the courses. You can experience it yourself. But this just shows you again, kind of a screenshot of how it's set up. There's a dashboard, there's different resources, different tip sheets. Next slide, that parents can kind of go to. Different interactive activities that they feel, like I said, that they're going to go through just really from their own lens of what's important to them. And then next slide. Like I said, they've got the resources. You can see these are a couple of like the tip sheets that are included in the online course. So if they want to dive a little bit deeper into a specific topic, these are just very specific strategies that could help with things like managing tantrums or managing things like separation issues that a child might be having. So lots of different resources. Again, parents can go back to it as many times as they want. I mentioned they have access for 12 months, but if a parent reaches out and they ask us to extend that, we extend it. We just extend it. That's it. We'll say, sure. And they can have access longer. And we do get parents that ask for that. They're like, oh, I didn't realize it was expiring. Great. No problem. We'll extend it for another 12 months. And if you need it for another 12 months after that, just reach back out. All right, next slide. Okay, and then I mentioned that we've got coaches at Nationwide Children's Hospital that are available. They're available statewide. Most of the Triple P work they do, of course, is in the Central Ohio area, but they do have a contract with the Children's Trust to be able to provide coaching to any parent around the state that might want and benefit from extra support. They can offer up to 3 sessions with the parent to really help reinforce what they're learning in the online course and help kind of clarify it and help support parents in coming up with their own plan for how they're using the strategies. So they're there to really help, parents set the goals, reinforcing those strategies, and then promoting that self-regulation. So again, those coaches are not there to tell the parent the right way to do a strategy they're really there to help reinforce the parents' learning and the parents figuring out what it is that they want to work on. And I should say, when I say parents, caregivers, aunts, uncles, neighbors, grandparents, all the things, nannies, babysitters, childcare, anybody that's around little people and helping them can benefit from some of these strategies. All right, and next. Okay, so this is the link again to the website where you can go to see all the things. Like I said, parents, when they go here, they're able to check out what it is about this. There's a video that shows them how the online course is structured so they can kind of get a feel for it if that's what they want. They can look for other sessions that are available. Nationwide Children's Hospital is also offering seminars that are virtual, just to kind of dip your toe in. So I think I don't know if it's on the calendar yet, but I know they're planning some more for, I think either late March. But they're going to run some just general parenting seminars, both for parents with younger kids and those with tweens and teens, that parents can just camera off like y'all are, just show up, listen to someone like me talking about different strategies and ideas, and they don't have to participate. They don't have to raise their hand. They don't have to say anything about what's going on for them. They can just learn some things, have a light bulb, maybe learn about what else is available. And if it piques their interest, hopefully they'll take advantage of some of the offerings, whether it's online or whether it's something else that a practitioner or a trained provider might be doing in their community. So that's the website you can go to, English and Spanish, and check it out and find those resources. And I think that's pretty much it. I think it's just my contact information. And then if there's questions.
Courtney, thank you so much. Your passion comes through in your work, and I appreciate the kind of America perspective and then bringing it back to Ohio. Very impactful for our participants. Any questions on Triple P for Courtney?
Great. Thank you so much, Brooke, for letting me join. And I really hope you all will, help promote it and just check it out for yourselves, and don't, hesitate to reach out to me. If anybody does have questions or you want more information, I'm happy to meet with folks one-on-one, happy to share any more details. So thanks.
Thank you so much. Appreciate it.
Thanks.
Okay, we have plenty of time to go over QI Corner. I'm going to stop sharing and then reshare a screen with sound. If you cannot hear it, please let me know.
Hello, and thank you for joining our session on motivational interviewing techniques to improve patient engagement. This is a rapid learning series. I'm Ronnie Christopher. Let's dive in. We're talking about a tool in motivational interviewing theory called OARS. It's an acronym that stands for open-ended questions, affirmations, reflections, and summary. So let's look at it with a patient engagement conversation. Open-ended questions are questions that require more than a yes or no answer. You don't want to ask the question where the answer can only be yes or only be no. You leave it open-ended. In this scenario, let's say we have a patient who has said, I'm frustrated with my weight gain and I really know I need to lose weight and I don't know what to do about it. So with an open-ended question, you might say, can you tell me a time when you've had success losing weight in the past? Maybe our patient says, when I can control carbs, I usually do pretty well. And that has worked. I just don't know yet. So we hear in the patient here that they've done something that has worked, but they're not sure they can do it now. With affirmation, what we say is, okay, so it sounds like you have had success losing weight before, and we can build on that. You're acknowledging something that they've done, that they've tried, a strength that they have, giving them some feedback that is encouraging in the affirmation. With reflection, you start to understand, what are the pros and cons of trying to make a change. So in affirmation, I say, it sounds like you've had success in the past, so you know you can do it, and that's a good thing. It also sounds like you are not sure if cutting carbs right now is going to work for you. Tell me a little bit more about that. Maybe our patient tells us that, I'm so stressed out. It was a lot of work to meal plan. I don't have time. I just don't know what to do about it. And I don't know if I want to cut out all my carbs just yet. So in reflection, you say, so what I'm hearing is that maybe reducing some carbs could help you lose weight, and that's important to you as losing weight. And I'm also hearing that, doing it with a lot of rigor right now might be a little challenging. So let's see what we can do. You might start to problem solve some options, and maybe you start small with the patient and say, instead of taking on all your carbs, maybe we can just start reducing a carb a meal. Is there a meal during the day when you are eating more carbs than usual that you might be able to cut back on or eliminate? Maybe our patient at this point says, I could probably cut bread out at dinner. That's something I've been thinking I should do. I know I should do it. I think I could probably do it. So we say to the patient, okay, let's set a goal for that you're going to try to cut down your carbs every day at least one meal. You think dinner will work. We're going to document that, and we're going to encourage the patient to test that and try it before they come back for their next visit. In summary, what we're going to do is really talk to the patient about what the plan is. So we're going to summarize that, okay, we've agreed that you're going to focus on some small changes. They're going to be focused around reducing carbs. You're going to reduce them at meals, and you're going to think about if that's working for you. And so that is how we think about OARS, and can use it to accelerate a conversation with our patient that helps us set self-management goals. Remember that you want to set small in between visit goals, and you want to make them manageable and doable and time bound and small enough that the patient can have success. You want to document the goals for follow-up so you can track progress over time. And you can use your portal as outreach to confirm or to offer more affirmation and messages to encourage the patient in between visits. So thank you for joining us on our rapid series for motivational interviewing techniques using OARS.
Okay. I think that Ronnie Christopher's good information on motivational interviewing and OARS can be applied to the SEEK program and beyond. Okay, so next steps, I'm just echoing what's been sent in the emails lately. So if you could, we'd love to talk to you for practice coaching call number 2. Would also love to get that done in March, but if you need to go into April, we'll talk about that. Just let me know. And if you have questions on your next PDSA worksheet or haven't submitted it yet, if you could also get that in this month. And then the next action period call, so the 4th one, is coming up on tax day, April 15th. Looking forward to seeing you then. Always let me know if you need additional resources or have any questions. I'll be sending out your individual data and then the slides from today. And I will also let you know when the recording of this session has been posted. Another little plug for Ohio AAP is our spring meeting. We're taking a different approach this year. We are having a Spring Advocacy Day. All of you are welcome. It is Thursday, April 10th at the Ohio State House. Registration QR code is there. Again, I'll be sending this out, but we would love to see you at the State House in April. Any questions from anybody regarding anything you heard today? Okay, hearing none, please know you can reach out anytime. I rarely am able to give you time back on these calls, but today I can do that. So please, thank you for joining and have a good week.